be talking about hypothyroidism and some of the pathophysiology and etiology, the signs and symptoms, some of the diagnostic evaluations, and how we treat it. As we went over hyperthyroid, and as you go through this and you look at all the signs and symptoms, if you just have working knowledge of one, you can just do the opposite for the other. So when we talk about primary hypothyroidism, this is the condition that arises from inadequate amounts of thyroid hormone in the bloodstream. Primary meaning it is caused by the thyroid itself. And for our purposes this semester, we're only going to go into the primary hypothyroidism. It can also be caused by autoimmune disease, such as Hashimoto's thyroiditis, which we're going to talk a little bit about later. And that's where you're going to see that progressive disease of the thyroid gland, and that's caused by infiltrates, of lymphocytes. And it destroys the parenchyma of the thyroid gland, and it produces hypothyroidism if it's left untreated. Use of radioactive iodine will also is one of the other forms of this condition. Destructive suppression or removal of all or some of the thyroid tissue by a thyroidectomy. We talked about that with hyperthyroid. If we had to take it out, then they'd have to be on Synthroid the rest of their life. Dietary iodine deficiency can cause hypothyroidism. Lithium therapy and overtreatment with any kind of anti-thyroid medications, such as your methimazole, tapazole, and PTU. So this slide just shows us a picture of some of the signs and symptoms of hypothyroidism. We have fatigue and lethargy. We have weight gain, complaints of hands and feet that are cold, temperature and pulse become very subnormal, reduced attention span, impaired short-term memory, thinning of hair, loss of the lateral 1/3 of the eyebrow, menorrhagia or amenorrhea. They have difficulty conceiving. They may have neurological signs, ataxia, muscle aches or weakness, clumsiness, hypercholesterolemia. They may have an enlarged heart on chest x-ray, increased susceptibility to some sedative type drugs, anesthesia type drugs. So this slide kind of goes over it in a nutshell, and it gives you some visuals about what this patient feels and what they'll come in with. Remember that it's low levels of thyroid hormone, hypothyroid, can occur throughout the lifespan, may be due to low levels of iodine ingested, and it results in that decreased metabolism. That non-pitting cellular mucinous type edema is formed everywhere, and that term is called mixed edema. The incidence most often ranges from 30 to 60 years of age, and it affects all body systems, as does the normal thyroid. Mixed edema is deficiency in thyroid synthesis in the adult, and you'll see that throughout their body. And a goiter is iodine deficiency that can also be caused by hypothyroidism. The diagnostic evaluation, I don't know if I have it on a slide or not, but I really want to take home this message, is that with primary hypothyroid, you will have a low T3 and T4 level. You'll have an elevated TSH level, and you'll have elevation of serum cholesterol. Your ECG you'll show sinus bradycardia, and if this disease is caused by Hashimoto's thyroiditis, you're going to have an elevation of thyroid peroxidase antibodies, and your thyroglobulin antibodies will also be elevated. So it's totally opposite of hyperthyroidism. You have to have working knowledge of that. Let's go back for a second. So when we take care of this patient with I wasn't sure I wanted to go to this slide yet or not, but I'm going to go ahead and go over it. Hashimoto's thyroiditis is that autoimmune disorder of hypothyroidism. Just like Graves' disease is the autoimmune disorder of hyperthyroidism, Hashimoto's thyroiditis is hypothyroid. And I can't say that 3 times. I know I can't. Anyway, but this is the autoimmune disorder. The cause is unknown. It's believed to be genetically transmitted, and they think it may be related somehow to Graves' disease, and that's enough to drive you crazy right there. And it's possibly the most common cause of adult hypothyroidism. And basically, the clinical manifestations are a little bit different. It's marked by a slow developing firm enlargement of the thyroid gland. Usually there's no gross nodules that are seen. The basal metabolic rate is usually low. You can have periods of hyperthyroidism caused by large amounts of T3 and T4 that's being released into the bloodstream. Usually the T3 and T4 may be normal, but usually becomes subnormal as the disease progresses. And remember that our TSH would be high with this type of patient. And they always have those antibodies, those anti-thyroglobulin antibodies, and will always be present. This slide just kind of basically goes over the signs and symptoms, and the management is hormone therapy for life. Your synthroid, cytomel, levothyroxine, and if need be, if they have a huge goiter and this is causing the thyroiditis, they may have to remove it. This slide we've already gone over, but repetition is good for the soul. Primary thyroid disease is 95% of the cases. We're not going to talk about secondary. The screening test is your serum TSH, and your treatment is to replace the thyroid hormone that is missing. And here's a patient that has mixed edema. You can tell by the face and the jaw and the overall edema. You can see that really, really well also in the extremities. This just gives you some of the signs and symptoms that we've already gone over with hypothyroidism. Remember that it's opposite. The lab assessment is opposite. Hyperthyroidism, T3 and T4 are decreased, and we have a TSH that's high in our primary. Our nursing diagnosis, decreased cardiac output related to altered heart rate and rhythm as a result of decreased myocardial metabolism, and that can also lead to chest pain as well. Ineffective breathing patterns related to decreased energy, obesity, and fatigue. Disturbed thought processes related to impaired brain metabolism and edema. Constipation related to decreased appetite, decreased food intake, diminished physical activity, and reduced peristalsis. So what are our expected outcomes with our patients with hypothyroidism? We want to maintain that heart rate above 60, maintain that blood pressure within normal limits for age and health. We don't want to have any dysrhythmias. We don't want bradycardia. Or we want O2 sats at least 88% minimum. Absence of cyanosis, maintenance of cognitive orientation. we want them to, their memory and their memory loss to be better, communicate clearly and appropriately. We want to monitor respiratory rate, the regularity and the effort, monitor temperature, circulatory status, monitor INO, monitor mental status and memory, and also should be on there is also to monitor weight. We'll go back to this slide. And what we notoriously give for our patients that for medical management with our patients, we give thyroid hormone, which is our T4 levothyroxine, also called synthroid, levothyroid, Levoxyl. You'll see maybe Cytomel, Armour thyroid replacement. Those are usually the typical treatments of choice. What is real important that if they've started on levothyroxine, they need to stay on levothyroxine. If they've been on synthroid, they need to be on synthroid. There are some studies done that I think there's like a 28% difference when they change over. Either it could be too much or too little of the thyroid hormone, so they need to be on the same, if it's generic or if it's a trade, and they need to stay on that. If the patient comes in myxedema coma, which is kind of like the same thing of a thyroid crisis to hyperthyroidism, myxedema coma is to hypothyroidism. If they come in, they usually give T3 is usually given if the patient's unconscious, given via nasogastric tube. They'll go ahead and give sodium levothyroxine, which is synthroid, parenterally to restore the T4 level. We want to monitor when this patient comes in, and hopefully they don't come into the hospital. We can get this before and pick it up in our clinics, but we want to monitor to anticipate treatment effects. We want to make sure they diurese, they decrease puffiness, they improve their reflexes and muscle tone, they have an accelerated pulse rate. And usually if they've had a myxedema crisis, all the signs of hypothyroidism should disappear in about 3 to 12 weeks. And then we have that decreasing TSH level. So we have to monitor that. So we need to do in our nursing interventions, we need to monitor our vital signs frequently to note any changes in cardiovascular status and ability to respond to stress, monitor EKG readings, prevent any chilling of our patient, because that puts strain on the patient's heart. Avoid rapid rewarming techniques because the resulting increased oxygen requirements and peripheral vasodilation may worsen that cardiac failure. So we need to do whatever our rewarming needs to be done very slowly. Administer fluids very cautiously. Administer all meds with caution before and after thyroid replacement begins. Monitor the effects of sedatives, as you know. Always report any occurrence of angina. Be alert for any signs and symptoms of myocardial infarction and cardiac failure. Monitor ABGs. And when we teach our patients, we need to instruct them that they're going to have lifelong thyroid hormone replacement. They need to know how and when to take the medications. They need to know that they need to take the synthroid first thing in the morning on an empty stomach. They can eat 30 minutes later. Very important. signs and symptoms of insufficient and excessive medication is important that we teach our patients. If they start feeling nervous, they may have too much synthroid. If they start feeling tired again, then we need to recheck their TSH. That's basically what that's saying. We need to monitor their fluid intake, use of fiber to prevent any constipation, control of dietary intake to limit calories and reduce weight. And there's the American Thyroid Association, which is www.thyroid.org, is a wonderful resource for our patients. If they have computers, that would be a great resource for them. Okay, the next slide, let me go back up again. This is about creatinism, and I kind of talked a little bit about this before I started talking about hyperthyroidism, but usually this is a very silent baby, severe hypothyroid condition of infancy due to deficiency of that thyroid hormone during fetal life or soon after birth. And the scary thing about it is, because we know that the thyroid gland regulates growth and development, these children do not grow and develop normally, and without the thyroid medication that they need. So that's why they check them during infancy before the child goes home, or maybe in 3 or 4 days, after the mama brings them back to the pediatrician's office. But these are some nursing assessments, and hopefully it doesn't, that you don't see it that much. It's very rare, but this baby would progressively be physically and mentally retarded, have shunted stature, wide open mouth, and kind of a lolling type tongue, which is like no control, small eyes and half closed, with eyes half closed with swollen lids, kind of a stolid, expressionless kind of face, a squatty figure, and some muddy, dry skin. But hopefully, I think I've only seen this one other time where a physician had diagnosed it before that was even required that they do the thyroid testing on infants, and the child grew and had to be on Synthroid the rest of their life. So, all right, that ends our hypo and hyper. We will go on, probably it'll be tomorrow or the next day. I'll do the parathyroids, and then we'll be ready on Thursday for diabetes. All right, hope y'all have a great weekend, and remember, if you have any questions, the Q&A on Blackboard, and I'll get to those when you, if you need me. Thanks. Have a great weekend.